Okay, good morning, everyone. It's my great honor to introduce the next speaker, Professor Satoshi Minoshima. Professor Minoshima get his MD degree in Chiba University School of Medicine, Japan, and he was the resident training, took the resident training in Chiba University Hospital, and then he have a experience as the postdoctoral training in University of Michigan in US, and he also earned his PhD degree from Chiba University School of Medicine. Right now, he is the professor of a Department of Radiology and Imaging Science, University of Utah, and the chair of a Department of Radiology and Imaging Science, University of Utah, and Annie G. Osborne Chair, Department of Radiology and Imaging Science, University of Utah. He also is the faculty in residency partner of innovation, venture, outreach, outsearch, and technology in terms of PIVOT Cancer Center. The title of his talk today is Brain Molecular Image and Therapy in Dementia. Professor Minoshima, please.
Oh, thank you so much for kind introduction. Thank you so much for inviting me to the Taiwan Society of Nuclear Medicine meeting. I'm really honored. I just came back from SNMMI annual meeting in Vancouver. Somehow I lost my voice during a meeting, so I hope you can hear me okay. I'm going to talk about brain molecular imaging and therapy in dementia today. And today's talk, I'm going to briefly talk about clinical brain imaging and FDG, also amyloid and PET imaging and amyloid, anti-amyloid therapy, and some discussion about non-amyloid pathology in Alzheimer's disease, and also new disease and co-pathology, as well as cost of dementia care and the fluid biomarker. So starting with clinical brain molecular imaging and FDG PET. It is actually pretty exciting time in the United States. If I take a look at how many radio tracers available in the clinic. So for dementia workup, we have a glucose FDG, but also 3 amyloid tracers and 1 tau tracer. These are approved by FDA. Reimbursement is still limited, but we can actually use this in the clinical setting. Is a huge advancement. And also for the movement disorder, DAT scan as well as F-DOPA has been approved by FDA. And the epilepsy, we have been using FDG PET. So there is an increasing number of radio tracers available for brain molecular imaging. From an instrumentation viewpoint, there has been a huge advancement in the last several years. So PET detector crystal is getting smaller and smaller. And this is combined with a digital detector, SIPM. So it's a silicon diode photomultiplier. So this new generation of detector really actually makes high spatial resolution and also high sensitivity, and produce remarkable brain PET images. And this is just one patient from the clinic. This is not the champion image, but you can actually see remarkable spatial resolution and the signal to noise ratio. And if I overlay this FDG scan with MRI, so this is a T1 weighted MRI from the same subject. If I go back and forth, you can actually see remarkable correspondence. And just magnifying part of the brain, you can actually see gyri and the south side on the FDG PET scan, almost comparable to what you can actually see on MRI scans. So it's really an amazing time, advancement in the radio tracers, but also advancement in instrumentation. This actually gives us a huge foundation for brain molecular imaging. In 90s, we pioneered creating a statistical brain mapping technology, and this actually became widely available in a clinical workstation. If you actually take a look at the Alzheimer's disease, dementia with Lewy bodies, and the frontotemporal lobe dementia, those three disease categories, these are basis for differential diagnosis. This is a Z-score map, color coding area of decreased FDG uptake, Alzheimer's disease, parieto-temporal lobe, and the posterior cingulate precuneus as well as frontal lobe, but sparing a primary sensory motor cortex and the primary visual cortex. Dementia with Lewy bodies is similar to Alzheimer's disease, but occipital lobe, in particular primary visual cortex, is also involved. So this can give a differential diagnosis between Alzheimer's disease and dementia with Lewy bodies. And the frontotemporal lobe dementia, this is a behavioral variant of frontotemporal lobe dementia, clearly frontal dominant hypometabolism compared to Alzheimer's disease and dementia with Lewy bodies. So FDG PET and using a statistical mapping can actually give us a basic kind of a performance, differential diagnostic performance using FDG PET imaging. But in the last 10 years or so, there has been clinical variants and the subtype classification in both Alzheimer's disease as well as in the frontotemporal lobe dementia. So for example, Alzheimer's disease, now we recognize a behavioral variant of AD, or often called frontal variant of Alzheimer's disease. Also, Alzheimer's disease can affect occipital lobe, which is often called posterior cortical atrophy. And also, dementia with aphasia, logopenic variant of primary progressive aphasia is often Alzheimer's pathology. Within the frontotemporal lobe dementia, used to be a Pick's disease. Now, clinically, these patients are behavioral variant of frontotemporal lobe dementia. And also another types of frontotemporal dementia is a primary progressive aphasia. And this is subdivided into semantic variant of PPA, which is often called semantic dementia, or non-fluent variant PPA, or logopenic variant of PPA. So this logopenic variant can have Alzheimer's disease as well as frontotemporal lobe pathology as well, and the movement disorders, PSP, and corticobasal degeneration. So over the decade, PET differential diagnosis, AD versus DLB versus FTD, this is still a basis for differential diagnosis, but within each category, there is now clinical variant and subtypes. These are classified. And if you actually take a look at the FDG scans on a Z-score map, you can actually see differential metabolic pattern of these are frontal temporal lobe dementia variant, semantic variant dementia, and or non-fluent variant or logopenic variant. So there are types of subtype of FTD manifest different distribution of decreased FDG uptake. And why this type of subtype classification becomes very important is because underlying pathology can be actually different. So behavioral variant of FTD or PSP CBD, or non-fluent variant or semantic variant of PPA, there is an underlying tau pathology. but also semantic variant as well as logopenic variant of PPA. There is a TDP43 pathology, and the logopenic variant of PPA also can have amyloid pathology as well. So I think clinical subtypes classification is more and more becoming important because underlying pathologies are different. And once more targeting therapy, such as anti-amyloid therapy, is being developed, then more finer classification of dementia and the neurodegenerative disorders, this becomes very, very important. Also, using statistical mapping technology, you can differentiate very early stage of Alzheimer's disease. And this is just one example of mild cognitive impairment. If you actually just take a look at the transactional FDG scans, it's very hard to say this patient really have Alzheimer's disease or not. But if you apply statistical mapping, you can actually appreciate there is a posterior cingulate reduction as well as parietal temporal metabolic reduction. So this patient is a very early stage of Alzheimer's disease. So statistical mapping really helps. And based on the review of the literature, amyloid positive likelihood of Alzheimer's disease of amyloid PET and statistically analyzed FDG PET, they actually almost have a same positive likelihood ratio of Alzheimer's disease. So that if you have access to statistical mapping technology in a clinical setting, I think using a statistical mapping really actually helps to improve detection of Alzheimer's changes as well as differential diagnosis. And the 3D SSP is freely distributed, now actually used in 54 countries, including Taiwan. Now, I would like to talk about amyloid PET and anti-amyloid therapy. And this is really an exciting field of development. If you take a look at the brain specimen, autopsy specimen of Alzheimer's disease, there is a senile plaque and neurofibrillary tangles. Senile plaque has amyloid deposition, and the neurofibrillary tangle has a tau deposition. And early 90s, Hardy and Higgins, they proposed the amyloid cascade hypothesis. In this hypothesis theory that initial abnormal processing of amyloid precursor protein resulted in abnormal amyloid A beta peptide deposition, which triggers neurodegenerative processes. And this is an amyloid cascade theory. In the 90s and 2000, there has been extensive molecular and the genetic research around amyloid cascade theory. Now we understand APP is cleaved by two different enzymes and then become abnormal A beta 40 and the 42 peptide, which accumulate in the brain and become a part of the neurodegenerative process. And if you take a look at the PubMed publication, FDG PET, amyloid PET, tau PET, and also inflammation PET and perfusion SPECT, since 2000, amyloid PET imaging, which is a blue line, the number of publications really increased dramatically. And now green line, which is a tau PET imaging, is also increasing. And then FDG PET scan continue to be a significant publication. I think those two imaging, amyloid PET and tau PET, Dr. Matsuda discussed in the previous session. And reflecting this enthusiasm to develop amyloid PET ligand, there are 3 F18 labeled radio tracers have been approved by FDA. And also there are lots of AI application in amyloid imaging. This is one example that from a Stanford group looking at the super low dose amyloid tracer injection and using MRI side information and the AI to produce full dose amyloid PET imaging. So lots of AI has been applied to amyloid PET imaging. And it's very interesting to realize that the deposition of amyloid and the glucose hypometabolism in the course of Alzheimer's disease, there is no one-to-one correspondence. As you can see on the top row, glucose hypometabolism occurs in the posterior cingulate cortex, then parieto-temporal and the frontal association cortices. But amyloid is more diffuse from the beginning, and especially medial frontal lobe, medial inferior frontal lobe has a very high deposition at the beginning and they gradually propagate through the entire neocortex. And even in the late stage, primary sensory motor cortex or primary visual cortex is relatively preserved on glucose metabolism, but amyloid deposition just diffusely involves primary cortices as well. So there are lots of topographical differences between glucose metabolic changes or hypometabolism versus amyloid deposition. And the exact reason for this discordance is still, we don't know clearly why there is such a spatial discordance between hypometabolism and the amyloid deposition. But using molecular imaging, I think one of the major goals is to detect disease early and accurately and guide those patient to a treatment and appropriate management with the hope that we'll be able to improve patient outcome. So last year, US FDA approved aducanumab as the first anti-amyloid disease-modifying drug. And this was a huge excitement, but also a confusion this approval actually has created. And this aducanumab is one of those antibody developed for anti-amyloid therapy. There are many other antibodies has been developed, went through the clinical trials, and some of them hasn't been approved. Some of them are still actually ongoing. And each antibody recognizes different part of the amyloid deposition as shown in this graph. And for the aducanumab trial, they included amyloid PET imaging, and you can see dose escalation response by increasing the dose over a year. There is a clear evidence that amyloid deposition measured by amyloid PET imaging decreased over time. So drug is working as intended, clearing amyloid deposition in the human brain. But this is not the first time to show that amyloid PET imaging demonstrating a decreased amyloid deposition with antibody trials. And this is 2010 Lancet Neurology publication that bapineuzumab antibody also clearly showing amyloid reduction after treatment. But unfortunately, clinical outcome didn't improve statistically significantly. And aducanumab, there are two clinical trials. So one of them is ENGAGE, and one of them is a EMERGE trial. And both of them actually included 1,600 plus patients, and so relatively large clinical trial. And both of them actually included PET imaging as a secondary endpoint. And if you take a look at the ENGAGE study, which is on the left side, clinical outcome, none of them are statistically significant. But EMERGE trial, almost the same number of subjects included. Some of the outcome are statistically significant. So there was a huge discordance between two trials they conducted. And we don't know why exactly there is such a huge difference between ENGAGE and EMERGE study. But FDA decided to approve, and this actually created a huge controversy. So initially, when this drug was approved, early diagnosis and treatment management, became possible, and hoping to improve patient outcome. But somehow this treatment management and patient outcome became questionable. There has been a lot of publications by major societal journals, controversy around Alzheimer's drug approval. And just summarizing why this first anti-amyloid therapy approval by FDA became so controversial, because still we do not know exactly if A beta reduction is really translate to a clinical improvement, because two trials, totally different outcome. And also both trials used amyloid PET imaging to demonstrate decreased amyloid deposition in the human brain. But is the A beta really is a valid surrogate for the treatment of Alzheimer's disease, because it doesn't translate to the clinical outcome directly. And once anti-amyloid treatment is approved, then there is a negative effect on the industry drug development. Many industry try to follow the same pathway, anti-amyloid treatment strategy, instead of looking for other types of treatment. Also, regulation kind of follows, so it's going to bias towards amyloid treatment. And some other collateral challenges are those patients on the Alzheimer's trial. Now they know there is a drug called aducanumab, and they drop off from other clinical trials. Also, aducanumab initial drug labeling indication was so wide and created a huge confusion, because trial was done with a relatively limited scope of patients, such as mild dementia. But the FDA approval was just Alzheimer's disease universally. So that was a huge confusion. The cost of the drug is very high, $56,000 per patient a year, and the patient has to be on the maintenance dose. And the company reduced the price after receiving criticism, but out-of-pocket copay of up to 20% by the patient. So this is going to be a significant healthcare spending for patient as well as for the society. And also MRI to monitor side effect area, amyloid-related imaging abnormality. And also this adds cost of the MRI and the complexity of treatment. And then finally, controversial FDA approval. Despite evidence wasn't very clear, FDA decided to approve this drug. So really put the clinician into a very difficult position when patient would like to use aducanumab, but clinician has to give a honest answer that this drug may or may not be the right treatment for Alzheimer's disease. This is one example of amyloid-related imaging abnormalities. So after the course of treatment, patient developed edema, as well as susceptibility-weighted MRI images show microhemorrhage. So these are two phenotypes of aducanumab treatment-related imaging abnormalities. And this area actually occurs quite frequently. 41% of the patients treated with aducanumab, and 21% of the patient is a hemorrhage, so more severe form of side effect. And the clinical symptom, 24% of the ARIA patient, and most often it's headache, but some other more severe side effect has been noticed. 88% of the patient recovers, 12% of the patient stays with the side effect. And if there is a severe ARIA H hemorrhage is observed, then serial MRI is recommended to confirm that hemorrhage doesn't increase in size and numbers. Then they can actually go back to treatment. And evaluation of ARIA for the E, neuroradiologist basically has to measure the size of the edema to decide mild, moderate, and severe. And for the area H, hemorrhage, neuroradiologist has to count number of microhemorrhages. And so this is actually quite a burden for neuroradiologists, actually reading a multiple serial MRI scans obtained from a patient treated with aducanumab. And this is really adding a complexity and a burden in patient care using aducanumab. And CMS, so in the United States, FDA approves safety and efficacy of the drug, and the CMS decides coverage and the reimbursement for the new technology. And despite FDA approval, CMS decided to approve this drug with only coverage with evidence development. So basically, this is a clinical trial funded by CMS. So CMS is asking if this treatment really improve patient outcome, or does this treatment cause ARIA, and how significant this ARIA findings are for the patient outcome. And also, once patient is on the aducanumab treatment, there is an annual maintenance dose, and how long do they have to continue therapy? Or if they stop therapy, is that going to be beneficial or harmful? So those three questions need to be answered in the coverage with evidence development. And the patient population was limited to MCI or mild AD dementia. So relatively early phase of dementia is approved for aducanumab treatment. But in this approval, only one amyloid PET scan is approved per patient if there is no prior scan. So still only one amyloid PET scan is approved for treatment of aducanumab. And challenging the amyloid PET and the therapy, there are several factors. So number one, amyloid cascade therapy theory and the clinical outcome still is not very clear. And also there is a prevalence of co-pathology in the elderly patients. You can treat amyloid, but maybe not treating other co-pathology in the elderly patients. And also cost and the coverage and the accessibility. So I'm going to explain those three elements. So non-amyloid pathology in the Alzheimer's disease. So Alzheimer's disease is a very complex pathophysiology, and amyloid deposition, in addition to amyloid deposition, there is altered transport, such as lipid transport, immune abnormalities, or neuroinflammation, or comorbid other brain disorders or synaptic dysfunction, axonal degeneration or axonal transport abnormality, and also impaired protein clearance, intracellular or extracellular, and also BBB breakage, impaired glymphatic changes. So all of those very complex pathophysiology. So the big question about the amyloid cascade hypothesis is that does the initial amyloid explain all of those pathology as a downstream event, or Alzheimer's disease actually have a multiple abnormal signaling pathway to start with? I think these are very big questions. So reflecting this multitude of pathophysiologies, drug companies are actually working on the different tactics. If you take a look at the biologics, which is a large molecule antibody treatment, you see a lot of red color circle and the inverse triangle. These are amyloid-based treatment. And if you take a look at the phase 3, it's all anti-amyloid treatment. So that's happening in the biologic domain. But the small molecule disease-modifying treatment, you can still see some red color, but there is really a wide variety of targets drug companies are actually working on. This is just reflecting how complex Alzheimer's disease pathology is. So amyloid is one pathway, but there are many other pathways which drug can actually target to slow Alzheimer's disease. And just some of those examples of non-amyloid Alzheimer's disease drug developments: anti-tau aggregation, anti-inflammation, synaptic vesicular protein modulator, and the sigma-1 receptor antagonist. And those four targets, we already have a PET imaging probes to evaluate drug effect, which is really exciting. And this anti-tau aggregate is probably the second to the amyloid, anti-amyloid treatment. I think very active area of research and development. And the tau is one of the microtubule associated protein. And when microtubule in dendrite as well as in axon disintegrate, then there is a hyperphosphorylated tau accumulate. And this is a target for tau PET imaging. And because of the pharmaceutical enthusiasm to develop anti-tau treatment, there has been many tau tracers has been proposed and tested. And the first generation of tau imaging had lots of background activities and also cross-binding issues, such as binding to MAO enzyme activities and other cross-binding challenges. But the second generation tau PET imaging clearly lower background activity and more specific to tau aggregates. And tau is a somewhat interesting target in the way that there is 3 repeat and 4 repeat tau, and each disease, Alzheimer's disease, CTE, or Pick's disease, FTD, PSP, corticobasal degeneration, they have a different combination of 3 repeat and 4 repeat tau proteins. And if you take a look at the protein holding based on the computer simulation, each disease have a different protein holding. So we just call it tau, but I think there is more complexity to tau aggregates and brain accumulation. But I just want to show this one paper published in Nature 2 years ago that using a cryo-electron microscope, we can actually visualize one tau molecule from a human brain extracted exactly the shape that predicted by computer models. And this is like amazing technical advancement that we can actually image tau deposition using PET imaging, and then using brain tissue extracted from a patient, you can actually visualize exact protein holding obtained from patient tissue. So I just want to show this slide, how this bioscience technology has evolved and advanced around proteinopathy in neurodegenerative disease research and development. Another challenge for anti-amyloid treatment is really a co-pathology and the new disease category. Co-pathology is recognized very often these days, and so Alzheimer's disease, pure Alzheimer's disease in the elderly patient population is becoming less common. Many Alzheimer's patients has a co-pathology such as TDP-43, or Alzheimer's disease can coexist with frontotemporal lobe changes such as tau TDP-43. And we used to work in nuclear medicine clinic and try to differentiate every case into AD, FTD, DLB. But I think looking at the more recent autopsy data, I think those dichotomous differential diagnosis, still we have to know how to do it, but that often is not good enough because major proteinopathies, they actually overlap, coexist in the same patient, especially patient above age 75 and 80. I'll just show you one FDG scan. This is Alzheimer's disease and progressive supranuclear palsy, which is typically considered to be one form of FTD. And the antemortem FDG scan shows frontal abnormalities as well as midbrain hypometabolism. Also, there is a precuneus, posterior cingulate, and the parietal temporal lobe abnormalities. But I think predominant feature of this FDG is a PSP, so frontal and the midbrain changes, but there is a mild Alzheimer changes. So if we do amyloid imaging in this patient, most likely amyloid PET imaging is going to be positive. But by using an anti-amyloid treatment for this patient, the major clinical symptoms comes from a PSP, which is frontal and the midbrain changes. So this type of co-pathology can actually significantly affect outcome of anti-amyloid treatment. Also, there are recently recognized dementia, and most notably limbic predominant age-related TDP-43 encephalopathy, which is abbreviated as a LATE. And all of those other dementia, new form of dementia, this affect hippocampus. And it's important to remember that hippocampal atrophy is not specific to Alzheimer's disease. In fact, if you take a look at the series of patients, hippocampal atrophy is more often seen in late and some other category of neurodegenerative dementias. And limbic predominant age-related TDP-43, this is something very important to remember, that prevalence is very high in the elderly patient age above 80, and investigators speculating public health impact is almost equal to Alzheimer's disease. Clinical symptoms are amnestic dementia symptoms, slow progression compared to pure Alzheimer's disease, affect mesial temporal lobe, and there is no molecular specific biomarkers. And if you do a FDG PET scan, this is a Z-score map overlaid onto MRI scan. The late patient, you can actually see more frontal changes, but also in the inferior view, you can see there is a significant metabolic reduction in hippocampus and the amygdala. And Alzheimer's disease, hippocampus and amygdala is involved, but it's relatively mild change. Dementia with Lewy body is even actually more preserved hippocampal mesial temporal lobe atrophy. And this is a neuroquant, so automatic volumetric analysis available in the clinic. You can see disproportional atrophy in the hippocampus. So this is a typical feature of late. But the challenge is that this TDP-43 pathology overlaps with amyloid as well as tau pathology, and in certain cases, alpha-synuclein. So all the proteinopathy-based classification, amyloid, tau, TDP-43, and alpha-synuclein, they actually overlap quite significantly, especially in the elderly patient, like age above 75 to 80. So this actually makes which patient we can really treat by amyloid, anti-amyloid treatment, that selection becomes very tricky because there may be some significant co-pathology exist in the patient, but we cannot visualize it because we don't have a TDP-43 imaging technology or alpha-synuclein imaging technology yet. So co-pathology and mixed dementia, very frequent occurrence in the elderly patients, and amyloid PET does not exclude significant co-pathology, and the outcome by anti-amyloid treatment becomes very uncertain. And the cost of dementia care and test, this is a very realistic question that we all have to tackle. So dementia care cost is going to increase over decades, and this is estimated by Alzheimer's Association. When aducanumab treatment was proposed, the price was $56,000. They immediately reduced to $27,000 in the United States. But this part of the cost is also ancillary cost test, exactly, examination and test. So having an MRI scan as a part of the monitoring, it is about $1 billion in the US Medicare. And also adding a PET imaging is going to be additional $2.6 billion. So this aducanumab alone is a very, very expensive treatment. And actually, it's a huge cost to the healthcare expenditure. So people are trying to come up with more affordable, readily available, and of course has to be reliable biomarkers, which is AD fluid biomarker development. And the fluid biomarker research started in 90s, but since mid 2000 has been really accelerated. So not only amyloid, but also tau, as well as alpha synuclein, and even TDP43 CSF biomarker has been developed. And now amyloid is really moving from a CSF to a plasma-based treatment. Few years ago, there was a seminal paper published in Nature by Japanese group, including a Nobel Award winner from a Shimazu corporate. They actually developed a high sensitivity mass spectroscopy to detect abnormal amyloid peptide in the blood. And their analysis actually showed the result almost equivalent to carbon-11 PIB PET imaging. And using similar but slightly different combination of biomarker, which is A beta 42 over A beta 40. And this ratio can also distinguish Alzheimer presence of amyloidopathy in the patient. And this is also published recently in neurology. And if you take a look at the FDA, there has been at least 5 breakthrough designation, all trying to support rapid development of plasma or fluid biomarker, mostly plasma biomarker development. So it's a very interesting time that amyloid PET imaging, tau imaging is really advancing quickly, but also plasma fluid biomarker development is moving forward very quickly. So today's discussion, I'd like to briefly summarize. So brain molecular imaging in dementia, it's really exciting time with the new tracers and advancement in the PET instrumentation, clinically available radio tracers, FDG PET and statistical mapping. Differential diagnosis is going into subclassification. It's very important, AD, DLB, FTD to AD subtype, FTD subtype. Amyloid PET imaging and anti-amyloid treatment, lots of controversy. And one of the reasons is anti-non-amyloid pathology, including a tau, and also new disease and co-pathology recognition in the elderly patient. And all in all, we have to be really realistic about cost of dementia treatment, and maybe fluid biomarker or combination with fluid biomarker and PET imaging is going to be the best way to care dementia patient. All right, thank you so much.
We thank Professor Minoshima wonderful talk. Because the time is limited, we have 2 questions from our audience. The first one is Dr. Tsai from Taiwan National Taiwan University Hospital. She asked about the information PET, like TSPO PET. Do you think the information PET, what is the role of information PET in the AD?
Yes, so using a TSPO as well as non-TSPO neuroinflammation PET imaging, there is clear evidence that neurodegeneration is associated with neuroinflammation. And this theory of neuroinflammation in Alzheimer's disease was initially proposed by Canadian researcher McGeer and colleagues in the 80s, and even tried to explain the amyloid deposition trigger inflammation, then complements are involved, and then microglia activation, then neuronal death. And so they try to put neuroinflammation in the very upstream of amyloid cascade. But I think there is evidence based on clinical trials such as anti-inflammatory drugs or anti-oxidative drugs, and all those things are not necessarily working in the clinic. And so pathologic evidence, imaging evidence, there is an inflammation. But by trying to modulate the inflammation and try to change the course of Alzheimer's disease, there hasn't been a huge success story. So I think this is a very important area we need to investigate further.
Okay, thank you. The second question, actually, there are two questions from Dr. Lin Kun Ru. The first one is, he said, I'm very impressed to see your movie slide of FDG and the amyloid PET from MCI to AD. Recently, more and more research focus on early stage of dementia subjects. Is there any PET image role in this field? Okay.
Yes. So question is, I think we should really focus on very early stage of disease, and just relates to inflammation as well. I think, if we can apply longitudinal study starting with a very early stage and ideally covering amyloid tau and neuroinflammation and the synaptic imaging, we can actually characterize natural.
Okay, I think he clarified his question is that he is asking about the application of amyloid PET for the people with subjective cognitive decline or the people with high dementia risk. Do you think the amyloid PET or other molecular image play any role in this stage?
Subject with cognitive, yes. So, I think once you go back to try to actually go earlier patient with only clinical diagnosis, the underlying pathology is so variable. And so unless if we have some sort of a confirmatory study, including longitudinal observations, it's very hard to draw causative conclusion from very early stage of that. So either you do a subjective, cognitive decline patient, but has a longitudinal study and then compare. I think it's a very important study, but just looking at the early stage is going to be very hard to conclude based on the imaging findings.
Okay, thank you. The second question is 3D SSP FDG seems to help a dementia differential diagnosis even in co-pathology condition. Do you have any experience to using AI technology in combination with a 3D SSP to facilitate its clinical use?
Yes. I think 3D SSP is already extracting the data from a transaxial scans, and so that's part of the data reduction is a part of the process. It's easy to apply actually AI or analytical-based automatic diagnosis method. We actually compared some of the very simple AI program using a 3D SSP versus human observation, and the results are almost the same. But coming back to like co-pathology, it's very hard for AI to actually pick up some of those confusing pictures unless if we give enough confusing cases as a training cases. So we haven't really tested those co-pathology cases with AI. We've only tested like a straightforward classification ADDLV versus FTD. Then AI can do well, human can do well.
Yeah. The other question from Professor Wu, he She asked about, do you suggest a regular follow-up after initial diagnosis and treatment and guidance of a pharmacological treatment by this functional or molecular imaging modality?
So if we can do this so maybe I can use the analogy of cancer treatment. So when we treat cancer patient, we do a FDG PET scan for the initial staging, and we treat and then do the follow-up FDG PET scan to see how many regions are responding, not responding. And eventually, if the region becomes FDG negative, then stop FDG scan. Amyloid treatment or tau treatment, I think ideally if we could do that would be really wonderful. But we don't have that amount of evidence to show second PET scan or third PET scan is beneficial for, let's say, amyloid treatment of Alzheimer's disease. So we still need the evidence to prove multiple amyloid imaging is useful.
Okay, thank you so much.